You're listening to Clinical Conversations, a Journal Watch podcast. It's for the week ending September 4, and it's podcast number 55. I'm Joe Elia. This week's conversation is about delaying or not delaying intervention in non-ST elevated acute coronary syndrome until the next working day. The short take is that it makes no discernible difference. First, a look at the week's principal clinical news. It looks like kids are going to need to get 2 shots when vaccinated against 2009 H1N1 virus. At least that's the CDC's best guess as of Thursday. Children with underlying conditions, especially neurodevelopmental conditions like cerebral palsy and muscular dystrophy, seem to be at increased risk for death from the virus and should receive priority in vaccination programs. And also on the H1N1 front, the Institute of Medicine has recommended that healthcare workers in close contact with H1N1 patients wear N95 respirators. Next, there's a non-surgical treatment for Dupuytren contracture. It involves injecting collagenase into the pathological restricting cord, waiting a day, and then trying to rupture the cord through manipulation of the hand. It was effective in about 2/3 of the cases. Finally, the New England Journal of Medicine released 2 studies on new drugs in heart disease. The first drug, dabigatran, was found at least as effective as warfarin in patients with atrial fibrillation at risk for stroke during a 2-year study. It offered a lower rate of major bleeding over the study period. The other drug, ticagrelor, was found superior to clopidogrel in patients with acute coronary syndrome with or without ST segment elevation. At the 1-year mark, a composite of MI, stroke, or death from vascular causes was significantly less common with ticagrelor. Both studies were industry-funded Phase 3 studies. More details are at podcasts.jwatch.org. Now, on to the interview. You're listening to Clinical Conversations, a Journal Watch podcast. This week's JAMA carries some research done in several high-volume French centers on whether immediate versus delayed intervention in moderate to high-risk acute coronary syndrome lowers the rate of myocardial infarction. There were some 300 patients studied, and they were randomized to either immediate angioplastic intervention, beginning on average about 70 minutes after presentation, or delayed intervention, averaging some 21 hours later. Peak troponin 1 values during hospitalization were similar in the 2 groups, and the rates of death myocardial infarction or urgent revascularization by 1-month follow-up were also similar. The study's first author, Professor Gilles Montalescot, has kindly agreed to talk with us. Professor Montalescot is at the Cardiology Institute of the University Hospital Pitié-Salpêtrière in Paris. Welcome, Professor Montalescot.
Hello.
Earlier studies have found similar results. What question were you trying to resolve with this study?
You know, in ST elevation myocardial infarction, it has been known for years that the earlier the better in terms of reopening the culprit artery. For non-ST elevation acute coronary syndrome, what we usually do is to give drugs first for a couple of hours or days and send the patients to the catheterization laboratory on the next day or on the next 2 days to have an angiogram performed. But we didn't know before if going more rapidly to the catheterization laboratory as we do in ST elevation MI would have an impact on clinical outcome. And that's what we tested here to apply what we do in STEMI, in ST elevation myocardial infarction, to non-ST elevation ACS, performing primary angioplasty to non-ST elevation ACS and see if it can reduce myocardial infarction in these patients with non-ST elevation ACS.
I see. So the difference was that in patients with STEMI, with ST elevation syndrome, you want to treat them right away. But
exactly, they have ongoing myocardial infarction, and they usually still have chest pain when we see them, and they have most of the occluded artery. While the patients with non-ST elevation myocardial infarction, they usually have a chest pain that resolves rapidly with medications. They may have an ongoing MI with a rise of troponin, for example, but we usually treat them, the next day, and we schedule a catheterization in these patients.
I see. Now, these were, as you say in the paper, high-volume French, the high-volume centers there in France, and but you say that the kind of approach taken, it mirrors probably what's seen in many community centers. Is that right?
Absolutely. What we needed to perform this study is to get the agreement of high-volume centers having already a primary PCI program, doing already primary angioplasty for STEMIs. And so we used these facilities and we use these programs to apply this strategy to non-ST elevation acute coronary syndrome. So physicians and at this site didn't have to start something new. It already existed for STEMI patients, and we just applied this program to non-ST elevation ACS.
I see. You mentioned that all of the centers used on these patients optimal medical therapy, and that, in fact, that fact could limit the applicability of your findings. Should centers thinking of adopting a next-day strategy, should they first optimize their use of medical therapies before proceeding?
Yes, one question in this study was related to the fact that some of the drugs that we use have a slow onset of action. So bringing the patients rapidly to the catheterization laboratory may expose the patients to some risk of myocardial infarction, possibly because the drugs were not fully effective. This is true, for example, for clopidogrel, which has a slow onset of action. So what we did is to use optimal medications using, of course, aspirin, which has an immediate onset of action, using anticoagulation, and using, on top of it, abciximab, which is a strong intravenous antiplatelet agent with an immediate action. So all these patients were well covered in both arms of the study with antiplatelet and anticoagulant therapy. So there was no difference between the two groups, and they were well treated and well protected by the drugs at the time of angioplasty. And the second point I wanted to make is that one arm was next day angioplasty, and what we tested is immediate angioplasty, and they had an angioplasty done, let's say, within the first 2 hours of admission, just like a primary angioplasty.
Yes.
And we found no difference between the two strategies in terms of preventing myocardial infarction.
You limited your follow-up, though, to 1 month. Is that right?
Exactly, because we did not expect to see anything further down the way. It's an acute situation and with an immediate strategy, and myocardial infarction is going to occur in the next couple of hours. So all these patients, anyway, went to the catheterization laboratory and had a PCI performed when it was needed. And after discharge, we could not expect anything else.
I see. So you don't have any plans then to follow up with these patients on a longer term?
No, I don't think this type of strategy could have a long-term impact, especially after what we have seen acutely. I mean, no difference really between the two arms. So we cannot imagine to have an impact, for example, on left ventricular function as myocardial infarction was the same in the two groups.
So for centers that are using optimal drug therapy now, that have standardized their care and have carefully done that, then you think that there is no benefit to immediate intervention, say within an hour or 2 hours, in patients with non-ST elevation acute coronary syndrome?
No, we cannot recommend to go faster than what people usually do at high-volume centers, which is to go to the catheterization laboratory on the next morning.
Okay.
However, we know that this kind of strategy, of slow strategy, let's say, consume resources, drugs, physician, and nursing time. And I don't know how it is in your country, but here in Europe and in France, we have a shortage of nurses. We have a shortage of beds a little, and clearly speeding up the process may have some practical aspects and economic advantages. And clearly what we have seen does not mean that we have to do it, but it does not mean also that we must not do it. So at least during daytime, when the cath lab is activated and when all the nurses are ready to work and physicians are in the lab, if a patient gets in with a non-ST elevation ACS and if the cath lab is free, you could do it.
Yes. All right. Well, do you have any advice for clinicians that they should start this policy immediately? If you could advise a hospital, would you? And they weren't doing this now, would you say? What would you tell them?
I would say if you want to keep up going with what you did before, sending the patients to the catheterization laboratory on the next day, this is fine with me. Now, if you think you can treat this patient on the day of admission because there is no reason to wait, or because it's a Friday, for example, and you don't want to make this patient wait until Monday, that's really something that we can recommend now, because we have done it in this study, and there was no downside.
Okay. All right, Professor Montalescot. Thank you so much for your time with us today.
Thank you very much for this invitation.
We're all ears at 1-617-440-4374. Give us a ring or drop me a note at jelia@nejm.org. Clinical Conversations executive producer is Adoriano. I'm Joe Elia. Join us next week. Enough said.